This is Dr. John Jones. I'm the Chief Medical Officer for Concord Medical Group. Today's presentation is on the topic of OB emergencies in the emergency department. We recognize that at many rural facilities and more rural facilities, which are losing their OB services, that the practice of obstetrics is not always happening in these rural communities, and patients often use the emergency department for emergencies related to their pregnancy-related condition. Today's topic is to touch on many of those, and we'll hope to do that in a successful fashion. I will say that this presentation is certified for continuing medical education. I believe that number is about 1 hour of continuing medical education based on the presentation today. I have nothing to disclose. No commercial support has been received for this presentation, and hopefully you won't see any bias within the presentation either, as I have nothing to disclose today. Again, this activity is certified for 1 hour of continuing medical education. That is through a compliance watchdog, a partner of Concord Medical Group. Our objectives today are to present common OB emergencies which might be encountered by the ED physician. Second, we're going to discuss specific pregnancy-related complications. And then third, we're going to consider treatment options to correct pregnancy-related complications. And finally, we hope to expand the knowledge of each provider who may be faced with treating pregnancy-related complications in the non-OB environment. Those are our goals today. We're going to go through this in a stepwise fashion using case studies, and hopefully you will find this educational in the opportunity that's being presented. Our first case study presents a 26-year-old female. She's gravid of 3, parent 2 at 12 weeks gestation. She's been suffering with nausea and vomiting for 3 weeks. She says she vomits all day, every day, and that has been going on for the last 3 weeks. She's lost 5 pounds in the last week. Her current vital signs are 98/56, heart rate of 119. She's breathing 21 times a minute. She's afebrile at 98.1. The question really is, what do we do next? As you see at the top of the slide here, this pregnant female has hyperemesis gravidarum, and our workup for hyperemesis should include a CBC, chemistries, lipase to rule out pancreatitis, ketones to get an idea of the level of hydration or dehydration that's present. We also want a urinalysis. We should start IV fluids. Normal saline or lactated ringers are great, but they do need to contain dextrose as well. This patient is depleted not only in terms of volume, but also depleted in terms of energy, and the dextrose will help with that and help clear the ketones in a more timely fashion. We want to give antiemetics as appropriate. Generally, some IV Zofran goes a long way in these patients with hyperemesis gravidarum. Our treatment should continue until the ketones are cleared, or at least almost cleared, and the patient is able to tolerate PO fluids and electrolytes are corrected. Any serious electrolyte abnormalities should be considered for observation or inpatient admission to the hospital. Prescription for outpatient treatment should include dicleges. This is an antiemetic which contains vitamin B6 and Unisom. In combination, under the trade name dicleges, this is a very expensive medication. You can encourage the patient to take over-the-counter vitamin B6 and Unisom and get the same results in treating this on an outpatient basis. A few points to make about hyperemesis. The risk factors for it are multiple pregnancy. Twin and triplet gestation certainly are a high risk factor for hyperemesis. Also, something to keep in mind is molar pregnancy. We want to rule that out with ultrasound if an ultrasound has not already been done. The symptoms: severe nausea and vomiting, weight loss, dehydration, and electrolyte derangement associated with pregnancy. That basically defines hyperemesis gravidarum. It generally occurs between 6 and 20 weeks gestation. It usually peaks between the weeks of 7 and 12. Supportive care is the treatment with IV fluids and antiemetics. At home, that treatment might include vitamin B6 and Unisom or doxylamine, or a prescription for dicleges. And also want to consider admission to the hospital for those with an inability to tolerate PO fluids, those with acidosis, or those with electrolyte abnormalities. We'll move on to case number 2 now. This is a 22-year-old female who presents with vaginal bleeding and pain to her right lower quadrant. The pain waxes and wanes, but it's been getting worse for 2 to 3 days. The pain is now severe, which has caused her to seek treatment in the emergency department. Her pain is rated as a level of 10 out of 10 and is constant. Last menstrual period was 9 weeks ago. Her physical exam shows tenderness to the right lower quadrant with guarding. Her vital signs: blood pressure 118/89, heart rate of 103, respirations of 22, and temperature of 99.3. Question now is, what do we do from here? In this case, the patient is going to end up with a diagnosis of ectopic pregnancy. That pain in the right lower quadrant and some vaginal bleeding being present is concerning, and their workup should include a pregnancy test in the quickest way possible. If the patient can't produce a urine in a timely fashion, a quantitative HCG by serum is probably the quickest way to go. We want to establish an IV. We want to get labs including CBC, type and RH, chemistries, and the quantitative beta HCG, and then an ultrasound to take a look at what's going on there in the right lower quadrant. The risk factors for ectopic pregnancy include prior STDs, pelvic inflammatory disease, the presence of an intrauterine device, previous tubal ligation. Please keep in mind that just because a patient's had a tubal does not mean they can't be pregnant. And if they are pregnant, actually increases their risk for a tubal pregnancy. Other risk factors for ectopic pregnancy include older age, African American race, a smoker, or recent abortion. Signs of ectopic pregnancy include delayed menses, abdominal pain, and vaginal bleeding. And the ultrasound should show the presence of an ectopic fetal pole, free fluid in the cul-de-sac, or an adnexal mass, and the absence of an intrauterine pregnancy. Always want to consult OB on these patients to discuss the treatment options. Those options may include surgery, or we may even manage this medically with the use of methotrexate. That should only be done under the guidance of an obstetrician. If you don't have an obstetrician locally, talking to one remotely at the tertiary center is the right thing to do. We move on to case number 3 now. This is a 29-year-old female. She's a gravid of 3, para 1011 at 8 weeks gestation. She comes in with abdominal pain, intermittent cramping. She's had vaginal bleeding for the last couple of days. She is soaking 3 to 4 pads per day, and she passed a clot just prior to arrival. She had a positive home pregnancy test a few days ago. Blood pressure currently is 113/88, heart rate of 99, respirations of 18. She's afebrile at 98.1. On physical examination, she has mild tenderness to the suprapubic area. There's minimal bleeding seen on vaginal examination, with some clots noted in the vaginal vault. We want to always note when we do this exam whether the cervical os is open or closed. What do we do now? The workup of this patient, it should include a CBC, a beta HCG, a type and RH, chemistries, and a urinalysis. This patient also needs an ultrasound examination. We want to establish an IV. As you see at the top of the slide here, this patient's diagnosis is spontaneous or threatened abortion. Risk factors for spontaneous and threatened abortion include a history of prior abortion or miscarriage. Other risk factors include maternal age greater than 40, alcohol use, multiparity, diabetes, thyroid disease, and a low BMI. The differential diagnosis should include spontaneous abortion, ectopic pregnancy, urinary tract infection, fibroids, subchorionic hemorrhage, trauma, and infection. We always want to consult the obstetrician due to the concern with the need for intervention, especially if the os is open. Serial beta HCGs may be noted if the patient is stable and can be done every 48 hours to track this pregnancy to see if the pregnancy is being lost or if the serial HCGs are rising appropriately for a normal pregnancy. In terms of procedural intervention, a DNC, a dilation and curettage, may be necessary when there are retained products, there are evidence of complications, large hemorrhage, or patient instability. Moving on to case 4, we have a 41-year-old female, gravid of 2, para 1. She's at 20 weeks gestation with a twin gestation. She presents with abdominal pain, which has been present for about 2 hours, and she's feeling contractions. She has no vaginal bleeding, Her vital signs are stable, blood pressure 104/76, heart rate of 76, respirations of 16, and afebrile at 98.6. On examination, she has mild suprapubic tenderness. The uterus is palpable between the xiphoid and the umbilicus, and the cervical os is open to 2 centimeters. What do we do with this patient? This patient is likely in preterm labor. If available, we want to place a monitor on the patient's abdomen to monitor for contractions and also fetal heart rate. On the vaginal exam, we want to perform that using a sterile glove, always a sterile glove, to check for a loss of fluid and to see if the os is open. In terms of lab work, CBC, chemistries, want to get a group B strep, GC and chlamydia, as well as urinalysis, establish an IV, and consult the obstetrician. Again, if that obstetrician is not available locally, calling one at the tertiary center would be wise to do. We want to transfer the patient if at all possible. If they're in active labor, the os is open to greater than 6 centimeters. This defines active labor, and the patient is considered unstable for transfer. In that case, you would want to mobilize resources to prepare for delivery of the baby or babies in the emergency department, and also get appropriate resources from the tertiary centers to help care for and transfer those babies when the time comes. Risk factors for preterm labor include maternal age, less than 17 or greater than 40, drug use or smoking, long-term stress, multiple gestations, as in our case when the patient was pregnant with twins, a low body mass index, placental abruption or placenta previa, frequent urinary tract infections, or bacterial vaginosis, all predisposed to risk factors for preterm labor. Fetal heart tones are normal ranges between 100 and 160. So if we are measuring those fetal heart tones with the monitor, that's the range we're looking for. We also want to see variability on the monitor, meaning the heart rate goes up and down periodically, and it should go up with contractions as well. In the instance of preterm labor, the goal is to make it stop. We don't want these 26-week twins delivered in the emergency department so early. That's just fraught with complications, and we want to make the effort to stop the labor that has started already. To do that, we would use IV fluids. We want to use tocolytics. Those are medications that help stop contractions, and those include magnesium sulfate and terbutaline. Those should be used after consultation with OB, gaining recommendations from them on how to slow this labor process. There are cases where we don't want to stop the labor process. Those instances include critical illness or compromise, a current intrauterine infection, the presence of abruption, eclampsia, premature rupture of membranes, and fetal demise. In those cases, we want to allow the labor to continue and may even want to expedite it in certain cases. Remember, when treating a patient with preterm labor, that giving IV steroids can be helpful to assist fetal lung development. Doses of betamethasone are appropriate in those cases. Moving on to case number 5. This is a 24-year-old female. She's gravid 3, para 1011 at 32 weeks gestation. She's had vaginal bleeding for about 4 hours, has had bleeding off and on with this pregnancy. A recent ultrasound showed a low-lying placenta. She had been placed on bed rest and had been on bed rest for the last 4 to 5 weeks. Her vital signs show a blood pressure of 99/56, heart rate of 112, respirations of 16, temperature of 98.4. Where do we go from here with this pregnant female with vaginal bleeding? The low-lying placenta should give us an indication that placenta previa could be present. This means that the placenta is overlying the cervical os and in the way of any delivery of the infant. In this case, we want to order lab studies, including CBC, chemistries. Always want to get coags and fibrinogen, as well as fibrin split products, as well as type and screen. We will establish an IV and give IV fluids. We'll also place the baby on the monitor, checking for contractions and also checking fetal heart rate. We want to consult OB as well. What we don't want to do is the bimanual examination. Any examination of the vagina and cervical os can result in increased bleeding, in fact, can result in uncontrolled bleeding and worsen this situation. Risk factors for placenta previa include multiparity, previous C-section, as well as age of the mother. Placenta previa is where the placenta is low-lying. It implants over the cervical os, usually causes painless vaginal bleeding as the uterus elongates or the cervix dilates. Again, a reminder, do not place anything in the vaginal vault as it can cause the bleeding to worsen. Moving on to case number 6, 25-year-old female, gravida 3, para 2. She presents at 34 weeks gestation with severe lower abdominal pain. The pain is the worst she's ever experienced in her life. It began while using cocaine at home, which she uses routinely. Her vital signs are concerning. She's hypotensive with a blood pressure of 72/41 and a heart rate of 143. Respirations are 22 with a temperature of 98.9. She's in severe distress due to pain, rolling around and clutching her lower abdomen. Fetal heart tone monitor shows that heart tones are at 94. Again, outside the range of normal and concerning because they are so low. What do we do now? What we do now needs to be urgently done. In this case, the patient has placental abruption. Our treatment needs to include multiple IVs as well as bolus of IV fluids. The patient is hypotensive and we need to work to get that blood pressure up. Lab work should include CBC, chemistries, tap and screen, oxygen, urinalysis, coag studies, urine drug screen, as well as a plan for possible mass transfusion protocol. You may want to consider O negative right away, especially if the patient does not respond to crystalloid bolus. Want to consider pain medicine, as this is a severely painful condition and the patient will require pain medication without a doubt. There's a possibility for rapid deterioration as well as a possible code. It is also possible to consider that if OB resources are not available and you're unable to resuscitate the mother, that perimortem C-section may be necessary. Risk factors for placental abruption include hypertension, eclampsia, age of the mother, smoking, the use of cocaine and other stimulants, and trauma. Symptoms include severe abdominal pain. Also, patient can result in DIC, death of the mother, and demise of the fetus. Perimortem C-section, it should be remembered, it should be done right away. Fetal viability declines after 4 minutes of maternal death. And in the case that this occurs, preparation and rapid C-section is necessary if the baby is to survive. Case number 7, 42-year-old female. She's gravida 5, para 4 at 40 weeks gestation. Comes to the emergency department saying, I'm delivering my baby. Having had 4 other babies before, she knows what she's talking about. Precipitous delivery in the emergency department ensues, and there are no issues with delivery of the baby or the placenta. Postpartum check, the mom's vital signs are concerning. Her blood pressure is 84/40, heart rate of 126 with respirations of 14, afebrile at 97.4. On examination, she looks pale. She's tachycardic and diaphoretic. Active vaginal bleeding is noted postpartum with blood-soaked bed linens. The patient is started on the Pitocin drip appropriately following delivery. The nurses note heavy bleeding and maternal heart rate increases. What do we do now? This is the presence of postpartum hemorrhage and is quite concerning in all cases. Studies to be drawn include CBC, coags, fibrinogen and fibrin split products, as well as type and screen. The possibility of DIC should be considered, especially in the presence of large amounts of hemorrhage. In terms of other things to do, we want to increase the Pitocin. Again, Pitocin is started routinely on postpartum females. This is to help reduce the amount of bleeding. In this case, we want to increase the regular dose of Pitocin in efforts to reduce hemorrhage. Other efforts can be made include massaging the uterus, considering giving misoprostol. Also, possibility of giving TXA should be considered. The dose for that is 1 gram IV as a bolus. Also want to consult OB. The causes to be considered for postpartum hemorrhage include the 4 T's: tone, trauma, tissue, and thrombin. The goal here is to fix it, whatever the cause is. We first have to identify it though. Tone represents uterine atony, where the uterus simply does not constrict and close off those vessels. Tissue would represent retained placenta. Trauma would represent lacerations that might have occurred as a result of the rapid delivery. Also, when we consider thrombin as the cause, that represents coagulation problems that might need to be addressed. Again, we need to determine which of the 4 T's is causing the hemorrhage and fix the problem. Postpartum hemorrhage is defined as hemorrhage of greater than 500 cc's. It can occur in the immediate phase, meaning less than 24 hours after delivery. It can also be delayed, occurring up to 6 weeks after delivery. The causes between immediate and delayed hemorrhage vary greatly. Risk factors include thrombin disorders, the presence of retained products or tissue in the uterus, also trauma, which might have occurred with a rapid delivery, the tone of the uterus itself, age greater than 35, Asian race, the presence of already having anemia, or body mass index greater than 35. Also, prolonged labor can be a risk factor for postpartum hemorrhage. Things to consider are mass transfusion protocol. We want to identify and treat the cause as rapidly as possible. Hemorrhage can occur without signs of external hemorrhage. If the patient is hypotensive and tachycardic and you don't find external hemorrhage, you have to consider the possibility of internal hemorrhage, which might have occurred with uterine rupture. This occurs rarely, but needs to be considered in the postpartum female who is hypotensive, tachycardic, with no evidence of external hemorrhage. The diagnosis of uterine rupture is made with CT scan and should be done right away once the consideration is made. Case number 8. This was a little simpler than the last 2. 25-year-old female, gravida 1, para 0 at 14 weeks gestation. She was assaulted and fell to the ground. Pain to the low back and right upper extremity are noted, and she has no other complaints. Her vital signs are great at 111/96, heart rate of 99, respirations 18, temperature 98.2. On physical exam, she's a little tender to the low back, but no vertebral tenderness. She has bruising to her left hand and tenderness to the distal humerus. What do we do now? While we want to avoid radiation in pregnant females, there are occasions when it's necessary. If we suspect a fracture, we always want to order the appropriate study and shield the patient appropriately. Appropriate studies may include X-ray or CT scan, remembering to shield the patient as best we can. Labs to be ordered are CBC, urinalysis, type in RH, as well as a beta HCG. If the mom is RH negative, give RhoGAM, even if mild trauma and no vaginal bleeding. We want to do everything we can to protect the future pregnancies and this particular fetus as well. The dosage of RhoGAM is gestation-based. If the gestation is less than 12 weeks, the dosage is 50 micrograms. If the gestation is greater than 12 weeks, we give 300 micrograms, and it must be dosed within 72 hours of injury to be effective. Always consider RhoGAM in cases of trauma, regardless of severity, at the time of any surgery or intrauterine procedure like manipulation or amniocentesis. Each dose of RhoGAM offers 13 weeks of protection. Case 9, 23-year-old gravida 1, para 0 at 31 weeks gestation. She presents with a headache and lower extremity swelling, also some nausea. Vital signs are concerning in that she's hypertensive, blood pressure 176/110, heart rate of 98, respirations of 16 with a temperature of 98.6. On examination, she does have lower extremity edema of about 3+. She also has clonus on examination of her lower extremity reflexes. During the assessment, she has a brief seizure, which is quite concerning to you and your colleagues. The question now is, what do we do now? This patient presents with hypertension and a classic presentation of syndrome and symptoms consistent with pregnancy-induced hypertension, preeclampsia, and with the presence of seizure, true eclampsia. The goals here, first and foremost, is to stop the seizure. The way we do that is generally with benzodiazepines. They are generally effective in stopping these seizures and doing so rather rapidly. We then want to load the patient with magnesium sulfate. The loading dose is 6 grams to be given over 15 minutes, and then a drip of magnesium running at 2 grams per hour. May want to consider giving a beta blocker if the blood pressure does not respond to the magnesium. The beta blocker of choice really is labetalol. It works well in pregnant females and is safe to their fetus. Lab studies should include CBC, chemistries, urinalysis, and urine drug screen. We always want to consult an obstetrician in the case of preeclampsia and pregnancy-induced hypertension. The definitions and differentiations between the three. Pregnancy-induced hypertension, it occurs during pregnancy and it resolves postpartum. The syndrome can advance to preeclampsia, which is a persistent elevation in blood pressure that develops during pregnancy or during the postpartum period that is associated with proteinuria or the development of thrombocytopenia, abnormalities with the kidneys or liver, pulmonary edema, or signs or symptoms of neurologic dysfunction such as seizures or visual disturbances. Blood pressure elevation is mild to moderate. I do want to reinforce that this can occur postpartum, and ladies who present to the emergency room postpartum with continued swelling, headache, hypertension, and any of the other signs and symptoms of preeclampsia should be addressed right away and treated similarly to the patient who produces this pre-delivery. Severe preeclampsia represents all of the above that we talked about with preeclampsia. However, it has a caveat of a systolic pressure greater than 160 or diastolic pressure greater than 110. And then eclampsia is all of the above that we noted with preeclampsia with the presence of seizure activity. Risk factors for this syndrome include being less than 20 years old, prima gravida, twin or molar pregnancy, and smoking. Complications include organ damage or failure, placental abruption, fetal prematurity or demise. Options for blood pressure control, we've talked about many of those. Those include magnesium, labetalol, and even hydralazine. The key here is to do not use ACE inhibitors. These are not safe for pregnancy and should not be used in these cases. We do want to be aware of the potential side effects or toxicity of the magnesium. To look for side effects, you would look for hyporeflexia, hypotonia, lethargy, and respiratory depression. The key is identifying this in advance in order to avoid respiratory depression and the possible need for intubation. If you see signs of toxicity, stop the infusion and treat with calcium gluconate. Case number 10 points us to a patient who has severe complications as a result of pregnancy-induced hypertension. The condition is called HELP syndrome. The presentation is a 25-year-old female, gravida 4, para 2012 at 27 weeks gestation. She presents complaining of abdominal pain and has a history of gestational hypertension. The pain in her abdomen is in the epigastric and right upper quadrant areas. She's been present for 2 days now and is severe. She's vomited ×1. Vital signs show a blood pressure of 151/95, heart rate of 89, respirations of 16, and temperature of 98.1. On examination, the patient is tender to palpation in the right upper quadrant. Fetal heart tones are noted at 159. What do we do from here? The concern here is for HELP syndrome. The testing that we want to do includes CBC, chemistries. We want to get an LDH to look specifically at the liver, urinalysis, and lipase to rule out pancreatitis. We want to establish an IV, give IV fluids. We may want to get an ultrasound to rule out gallbladder disease, as it's part of the differential diagnosis. Pain management with Tylenol and/or morphine may be warranted for the right upper quadrant pain. Since the liver is involved, I would lean more towards the morphine or narcotic options and away from Tylenol in this case. The goals of management are blood pressure management, supportive care. We want to trend the labs and consider delivery at 34 plus weeks. The way to definitively treat HELP syndrome is delivery of the infant and the placenta. As we consider risk factors for HELP, they include age greater than 35, multiparity, Caucasian race, and history of miscarriage. HELP is associated with preeclampsia and eclampsia and should be considered in all of those cases. Anemia is due to hemolysis. The elevated LDH and hepatic transaminases are due to organ damage to the liver. There will be a presence of thrombocytopenia, an elevation in BUN and creatinine, representing kidney damage. May also see an elevation in bilirubin, which will be indirect, and that is due to hemolysis as well. The presence of abdominal pain, nausea, vomiting, jaundice, and headaches should clue us in to the possibility of HELLP syndrome being present. Case number 11 points us to a 35-year-old female gravida 4 para 3 at 37 weeks gestation. She has preeclampsia and presents with proteinuria and elevated blood pressure, along with clonus and lower extremity swelling. Her lab abnormalities include thrombocytopenia and elevated liver transaminases. She's noted to have a nosebleed and bleeding around both IV sites when the IVs are started. Some heavy vaginal bleeding is noted as well. On examination, her cervix is noted to be 4 centimeters dilated, 80% effaced, and she's at -1 station. What do we do now? In this case, this represents DIC in pregnancy. The concern here is that the patient's coagulation factors are not working appropriately or have been depleted. The goals of treatment are to stop the bleeding or control the bleeding. The tests that we need to order are a PT-PTT, fibrinogen, fibrin split products, D-dimer, platelets. May also want to get antithrombin activity and protein C activity. However, those tests are not usually available in primary centers located in rural settings. There is a scoring system which uses those tests to determine the actual risk of DIC in different cases. I find this quantitation a little difficult in that we cannot always get those tests in real time in our primary centers, and therefore I don't find the scoring system to be useful in our rural hospitals. I just want to present it to you for educational purposes. If DIC is present, we want to address the underlying cause. In this case, preeclampsia with HELLP syndrome. Delivery of the placenta is key. Fast and prompt delivery is important. We want to provide supportive care. IV fluids and blood transfusion may be necessary. We always want to have close clinical and lab surveillance, consultation with specialists if possible, including hematology, gynecology, etc. May need to activate our mass transfusion protocol, and then TXA is an option to help reduce the bleeding. May also want to give heparin in specific cases of DIC, but that should be done in consultation with specialists. Our next case is a 23-year-old female, gravida 1 para 0. She's at 39 weeks gestation. She's had gestational diabetes throughout her pregnancy. She has a small frame, but a high BMI. The baby is known to be large for gestational age. Vital signs include blood pressure 135/80, heart rate of 92, respirations of 94, and temperature of 98.1. On physical exam, the uterine fundus is at the xiphoid. The head delivers through the perineum, but then stops descent. After strong pushing, there's really no movement of the infant further in the vaginal canal. This is called the turtle sign, where the head delivers but then promptly pulls backward due to a problem with shoulder dystocia. What do we do now? Shoulder dystocia is a problem where the anterior shoulder gets hung up under the pubic symphysis. The goal here is to one, stop pushing, because any pushing just pushes that shoulder into the pubic symphysis and does not allow for the infant to push on through the vaginal canal. There are maneuvers that we can try to rotate the shoulder out from under the pubic symphysis and obtain delivery of the infant. The first maneuver is McRoberts maneuver. It requires 2 assistants, 1 on each side. They hold the mother's legs and hyperflex the patient's thighs onto the abdomen by bringing the knees to the armpits. There's a suprapubic pressure which may be used in conjunction with the McRoberts maneuver. As the knees are pulled back to basically the armpits, someone applies suprapubic pressure, trying to rotate the shoulder away and out from under the pubic symphysis. The pressure should be directed in a downward and oblique direction in the direction the baby's head is facing. This helps rotate the baby and dislodge the impacted shoulder. Delivery of the posterior arm is also possible if you can achieve that. Also, there are maneuvers called wood screw and the Rubin maneuver, which we will not talk about today, but can be looked at in further educational opportunities. Shoulder dystocia occurs when the baby's anterior shoulder gets stuck behind the mother's pubic symphysis, slowing descent and delivery of the infant. Maternal complications can be postpartum hemorrhage, perineal tears, vaginal and cervical lacerations, as well as bladder atony. There are complications which can occur with the baby as well. Those include brachial plexus injuries, hypoxia, fracture of the clavicle or humerus, and nerve damage. Our next case is a 27-year-old female, gravida 3, para 2 at 40 weeks gestation. She has a history of diabetes and hypertension. She presents in active labor and she's on the monitor. Vital signs include a blood pressure of 152/92, heart rate of 120, respirations of 116, and she's febrile with a temperature of 101.2. Fetal heart rate is elevated at 180. There's reduced variability, both long-term and beat to beat. Occasional decelerations are noted. What do we do now? What we have here is a non-reassuring fetal heart tracing. The baby's heart rate is tachycardic, and there's decreased variability, meaning there's not much wavering in the line from beat to beat or over the long-term section of the fetal monitor. The non-reassuring fetal heart tracing represents hypoxia to the fetus. We need to improve that as best we can. And ways we can do that is to give the mom oxygen by face mask. This should be a non-rebreather. We can change maternal position. We may want to turn her on her side, place her laterally or in the knee chest position, hoping to improve blood flow through the umbilical cord. We want to give fluids. Other things we can do are a vaginal examination with scalp stimulation. We want to determine the cause of the hypoxia and fix it. If the patient is on Pitocin, stop it and consider tocolysis. Might want to consider amnio infusion, although that's really more of an OB thing and would not routinely be done in the emergency department. And then C-section delivery may be necessary in the case of a non-reassuring strip. I want to caution you, if you do not have skills and privileges of performing C-section, this should not be done in the emergency department, except in the case of a perimortem situation. The way we interpret a fetal heart monitor strip, and again in the ER, hopefully you don't have to do this often, but we do want to monitor it and be able to interpret it as best we can. We want to correlate the accelerations and decelerations with contractions. And then is the fetal heart rate reassuring or non-reassuring, or is it ominous? Accelerations are good. When we see a contraction and the heart rate goes up, that indicates good blood flow and is an appropriate reaction to uterine contractions. Decelerations are a little more ominous, especially late decelerations, which generally represent poor flow of blood and oxygen to the fetus. When we see decelerations, especially if they are late and following contractions, we want to determine the cause and do the things that we can to improve oxygen flow to the fetus. Non-reassuring strips include fetal tachycardia or bradycardia, variable decels associated with a non-reassuring pattern. Late decels, as I described, would preserve beat-to-beat variability. Ominous strips include persistent late decelerations with loss of beat-to-beat variability, prolonged severe bradycardia, a sinusoidal pattern, and loss of beat-to-beat variability altogether. I know that we've touched on a lot of things, and we've gone through several cases. We've tried to touch on common things which may occur and be seen in the emergency department, especially in rural and local hospitals where OB care may not be available. And we've attempted to touch on how to treat those and how to address those and what we can do in the emergency setting before transferring the patient or in making a final determination of disposition of the patient. My hope is that we have met the objectives of our talk today to present common OB emergencies which might be encountered by the ED physician, We've discussed specific pregnancy-related complications, and we've talked about how to treat those, to recognize them first and then to treat them appropriately and make appropriate disposition of the patient. My hope is that this has expanded your knowledge and given you some education on how to handle these patients when they present to the emergency department. These can be complicated situations, and we want you to be prepared to manage them and manage them appropriately. I appreciate your time in listening to our presentation today. If you have any questions whatsoever, please feel free to reach out to me. My contact information is available at the end of the slide deck. Thank you for your time. Appreciate all the work that you do for Concord, and let me know if you have any questions. Thank you all. Have a great day.